So, you know, I come from the Chinese University of Hong Kong, so I send you greetings from my university, and especially for those delegates who are not living in Hong Kong. So I want to show you these photos to show you our beautiful harbor, and we have a lot of high rises and tall buildings in Hong Kong. In fact, the cost of living in Hong Kong is on the top of the world. Even though it looks like a fancy world-class city, but the living environment in Hong Kong actually is not that good. Yes, so this is a typical street scene in Hong Kong, and people majority of people just live in a very crowded small apartment, and the air quality is not that good. But you may be surprised to know one thing about Hong Kong, that is our life expectancy actually is the highest on earth. So this chart shows you the life expectancy in the last 15 years actually is continuously increasing from around 48 years old to 70 to 80. And since year 2016, the life expectancy of people in Hong Kong actually outperformed Japan. So you may wonder why people in Hong Kong live such a long life. We have not so good living environment, the air quality is not very good. So some people think that probably because of our lifestyle, the things that we eat, the kind of exercise, the Tai Chi that we are doing, all make a contribution to the long life. And also, I must say, I'm pretty proud of our healthcare system, because our healthcare system is very cost effective, very efficient and very effective. However, just by living longer, does it mean people in Hong Kong actually live better, or whether they actually die well? So this is the quality of death index shown in year 2015. And actually in Hong Kong, the quality of death index is not ranked very high. We rank number 22 out of 80 countries because of the high cost of expenses in palliative care, and also because of the limited supply of palliative care facilities and specialists. Now, this is the supply and demand chart. On the vertical line, you will see the supply, and on the horizontal line, you will see the demand. So in here, the cursor doesn't work, but I hope you can see on the right upper corner, okay? On the right upper corner of the chart is Australia and UK. Actually, this country ranked the top in quality of death index. That means they provide good quality of death care to their citizens. But the supply, both the supply and demand are pretty high in these countries. But in the right lower corner, you will see China and Greece. In this country, the supply is very low, but the demand is very high. So we have a lot of things to do in terms of end-of-life care and palliative care. In terms of the situation in Hong Kong, we know that only 1 in every 7,000 patients can receive palliative care in the public sectors. Probably our low index is based on the high cost of palliative care in private hospitals, the low supply of palliative care wards and beds, and the low supply of palliative care specialists. Now, globally, the WHO has published some key facts on palliative care. Every year, there's an estimate of 40 million people in need of palliative care, and 78 of them live in low and middle income countries. On the whole, only about 14% of these people who need palliative care actually receive it. And in many cities and countries, there's still some overly restrictive regulations for morphine and other essential controlled palliative medicines that deny access to effective pain and symptom management in many places. In general, all over the world, the healthcare system is lacking of training and awareness of palliative care among healthcare professionals, and this is considered a major barrier to improve access to palliative care. The global need for palliative care will continue to grow because of the aging populations and increasing number of chronic illnesses. So in summary, early palliative care is highly advocated to reduce unnecessary hospital admission and the use of health service. So when I prepare of this presentation, I can't stop thinking of a friend of mine. Her name is called Cindy. She's among one of the 14% of lucky people who can receive palliative care. So Cindy is a family friend of my family, and she was diagnosed with lung cancer 5 years ago, and eventually she died peacefully this year, early January. I think it's on the 3rd day of the Chinese New Year in January. So today, because I keep thinking of her, so I think I should tell you a little bit about her story. So my husband and I has a family tradition that we will host a retreat camp in the Noah Ark Parks every year. It's an annual retreat for our friends together, and then we learn and then we have fun together. And Cindy was a very courageous and tough cancer warrior. So she insisted to join our camp. And even though she said, I know what you guys are doing. I know you guys will sing, you will dance, and you will jump, but I know what I should do. I do whatever I can. So she insisted to join our annual retreat camp in the last 5 years throughout her cancer treatment. So I really admire her enthusiasm and positive thinking. And but early this year, Cindy's condition quickly deteriorates because of her brain metastasis. And her husband and I have a conversation in the hospital lobby. And she was admitted to the acute care ward in a hospital in Hong Kong because her husband can no longer take care of her due to her physical deterioration. And her husband said, a palliative care visited Cindy in the last few days, but I refused to let her go to the hospice. I think acute care hospital is better for her. And then I asked, what makes you come up with this decision? And her husband said, someone in this ward told me that no treatment will be offered in a hospice. So without painkiller, she has terrible pain. Without oxygen, she can't breathe. And without antiemetic, she keeps vomiting. I really don't want her to suffer more. So I said, it's totally not true. So I explained to her, I explained to him in details what is palliative care and what Cindy will receive when she admitted to a hospice. So after a long explanation, I asked him to reconsider whether you will let Cindy move to the hospice again. Then her husband said something. She said, the nurse told me that since I have chosen to move Cindy from Sha Tin Hospital to North District Hospital yesterday, so I already lost the opportunity to bring her back to hospice. So I feel very puzzled and confused about what he heard, probably a lot of misunderstanding, but I said, okay, let me try again. Trust me, I will try again to talk to the nurse, talk to the manager, and talk to the physician. I will try my best to let Cindy go to the hospice. So eventually, Cindy transferred to Bradbury Hospice the next day, and she died peacefully within a week over there. So Cindy's experience actually inspired me a lot. She made me think a lot about our current system of care. That how can we minimize misunderstanding in communication with the patient and family members? How can we enhance people in the public, their awareness and understanding of what is palliative care? They still think that in hospice, there will be no treatment. They will just abandon the patient in the hospice. And I'm thinking of how can we offer better transition from acute care to palliative care? How can we offer early palliative care? Does early palliative care means early home care, early referral, or early transfer? What does it mean? And we all know that we have very limited palliative care services and facilities. How can we tackle this shortage? How can we solve this problem? How can we make palliative care 24/7 available in acute care settings? So all these are very important clinical and research questions to me. So after a long introduction, here's come the outline of my presentation today. So I would like to give you an overview of the local and global challenges in palliative care and advanced care planning, ACP. I will share with you about my research journey on the promotion of ACP. Then I will tell you the development of a multimedia experiential advanced care planning facilitators training program in acute care setting. And lastly, I will share a bit about my reflection and my suggestions about opportunities to extend palliative care to acute care settings. So just a quick introduction and recap what is palliative care. Probably you know better than I do. Palliative care originates from the Greek word pallium. It means to cover someone by a crook. Okay, so if someone is covered by a crook, that person is receiving protection, comfort, and security. Disregard the cause of her discomfort. So palliative care is a broad concept aiming to improve the quality of life of patients facing a life-threatening illness through effective symptom management and a dignified death. And palliative care does not restrict to cancer or heart failure. It does not restrict to end of life. So it can be an older people, it can be a younger people, it could be even an infant with congenital disease. And in the integrated model of palliative care, you will see that actually there's a progressive transition from curative care to palliative care. So the earliest, the best. In the recent Cochrane review of literature, there's research findings showing that to have the best palliative care outcomes, if we want to achieve the best palliative outcome, actually palliative care should be introduced within 2 days after the patient is diagnosed with cancer. So we don't need to wait until a person is dying. We should actually introduce the concept and also the care within a very early time. And in order to implement early palliative care, first of all, the client and the family need to be aware of their right and privilege to make a choice. They need to know that actually they can have a choice to choose between invasive intervention or palliative care, comfort care. So we need to talk to the patient in an early phase. In respecting value and choices are two very important features and highlights in palliative care. So advanced care planning, ACP, is an approach of care. It's a patient-centered communication and shared decision-making about the goals and type of care when the patient is still comfortable and competent to make such planning. An advanced directive is a written document of a patient's preferred treatment and choices. So in the last decade, actually, advanced care planning or advanced directives are highly advocated in many healthcare associations all over the world. So it becomes a very hot topic for researchers, clinicians, and policymakers. We have research findings showing that facilitated ACP actually has multiple benefits. It will strengthen the patient's autonomy. It will improve the quality of care. It will also improve the quantity of care. That means the patients can live longer. And it has the potential to reduce the net cost of care because ACP can reduce hospital readmission and shorten the hospital stay. So it has many benefits. Let's take a look on the world, what is happening in the world. So many Western countries and many Asian countries, they have legislation on the use of advanced directive. For example, in the United States, in 1991, they have the Patient Self-Determination Act that make it mandatory for every healthcare professional to talk to the patient. You must talk to the patient as soon as they admit to the hospital, telling them they have a right to choose what kind of treatment. They have a right to receive the treatment. So it becomes mandatory in the United States since 1991. And similarly, in Singapore, they have the Advanced Medical Directive Act in 1996. And in Taiwan, they have it in year 2000. And advanced directives are strongly promoted. But we do not have legal requirements in most parts of China, including Hong Kong. So different peoples have various attitudes towards advanced care planning. We learn from the literature and research that non-white ethnic groups generally lack knowledge of advanced directives, and African Americans were consistently found to prefer the use of life support disregard what phases in their disease trajectory, and Asians and Hispanics, the Spanish people, were more likely to prefer family-centered decision making rather than individual making. So since Hong Kong is part of China and in the Asian area, we are greatly influenced by the traditional Chinese culture, highly value the family decision rather than individual decision. So you may ask whether ACP is feasible in Hong Kong. The answer is yes, because we have a lot of booklets, decision aid, leaflet, a lot of promotional activities happening in Hong Kong, all done by Chinese language. So APC is absolutely feasible in Hong Kong. And also we have huge organizational support, like in Hospital, Hong Kong Hospital Authority, in year 2015, I find this guideline in the HA website. They regard advanced care planning as the process of communication among a patient with advanced progressive disease, and they see end of life as everyone's business. We must start the conversation as a healthcare professional in a proactive, anticipatory approach. So the hospital authority also promotes ACP as an integral part of clinical care. However, that webpage has been published in year 2015, but in 2019, that means 4 years later, in one of my studies, I still find that only 18% of general public had heard about advanced directive. And in year 2019, we have hospital record data reveals that ACP discussion rate actually is very low. It's only 0.9% in palliative care settings. So you can imagine that the rate would even be lower in an acute care setting locally. And a common question about ACP is, when is the appropriate time to do it? And when is the appropriate time to start the conversation? Obviously, it's a complex issues and kind of complicated questions to ask, because in this chart, you can see the functional status of different type of patients has different manifestations. For example, cancer cases, the top one, you will see that generally the cancer patient can maintain their functional status pretty well until there's a sharp decrease of their functional status and a sharp deterioration of their overall conditions. For heart and lung cases, they have episode of attack. So if they don't have the episode, they are doing pretty well. But once they have the episode, they will sharply drop their functional ability and then gradually decline. For dementia cases, there's a prolonged and progressive deterioration of the functional status. So in order to capture the right moment to talk about ACP, we really need to do regular assessment and take a very sensitive approach to catch what is the right time to do ACP. And here's some challenges of ACP and AD from the literature. For example, people may have difficulty predicting what they would want in the future circumstances, because we are talking about ACP today with today emotion, today health status, and today values, today thinking. How can I predict what I will think in the future? It may be a year later or several years later. So it's a general concern of people that my value and my decision probably will change along my cancer or disease illnesses trajectory. There's still a lot of misunderstandings about advanced care planning, advanced directive. People may think, who will execute my written document? Who will have the legal liability of this document? And am I allowed to make change if I change my mind? So people still have a lot of uncertainties about advanced directive. And they may consider whether the facilities is available, even though I choose to stay in the palliative care ward, but when my condition getting worse, is the ward still available for me? And of course, family members have a lot of disagreement whether they should receive invasive care, life support care, or comfort care. And limited time is a common concern. It's not just for the patient, it's also for the healthcare providers. So the patient, no one can predict how many times the patient will have for this important discussion and communications. And physicians and nurses are very busy. They have limited time to sit down to talk to the patient. Also, they require training in terms of the conversation skill, resources, and team support. All these things should come together in order to make ACP reality. So in order to tackle these challenges, we propose early palliative care, early communication, and early training to the healthcare professionals. So in one of the conference, I have the opportunity to meet a lady and her family. Her name is called Linda. She was a speaker in the conference. Now, Linda, she is a housewife and she is a freelance journalist. Her husband is a pilot, and their family moved from Australia to live in Hong Kong with 2 beautiful children. So this is a typical middle-class, happy family until one day the elder son was diagnosed with leukemia in Hong Kong. So the whole family has to go through the treatment, the disease, the diagnosis, the ups and downs, many challenges for the families. So they receive treatment in a hospital in Hong Kong Island. So you can see the child actually has gone through a lot, and he has to deal with the homework and the chemotherapy at the same time when a nurse is giving her the chemotherapy. Now, Linda put all her observations in a book. So she wrote a book called Keep Walking to record her family experience of this child illness. And in one of her observations, she said something very interesting. She said the standard of medical care that we received was first class, but the general atmosphere and approach to care was a lot more institutional than in most other countries. So within 24 hours of receiving Jacob's diagnosis, we were given the patient conduct guidelines, a 2-page document of things that we are not allowed to do. And they are not allowed to leave the cubicle. They are not allowed to bring food. They're not allowed to bring outside food to the hospital. They are not allowed to sit on the patient's bed. A whole long list of things that they are not allowed to do. And they are required to read the document carefully and comply to it. So from the perspective of Linda, she thinks that the beautiful world-class medical care can easily be downgraded by a lack of sensitivity and wisdom. It's concerned the text of caring practice. So the text is a wisdom of what to say and do, or what not to say or do in a situations. It's a practical intelligence governed by insight while relying on feeling sensitivity and an authentic orientation to otherness. So this text of caring practice cannot be learned in a book, but we can definitely learn by experience and reflection of practice. So if we take time to sit back and review our practice, I'm sure we all find that something can be improved, and we will identify a way to do it better next time. So in my advanced care planning training program that I'm going to share with you later on, I will make sure that I include a lot of authentic experience and opportunity for reflection in my training programs. So most doctors and nurses doesn't know how to start the conversation. If you ask the patients, do you want us to do everything for you? Of course, the answer is yes. If you ask them, would you want to be kept alive as a vegetable? Of course, the answer is no. So these inaccurate and conflicting questions actually lead to inaccurate answer. So even though it's just a sarcastic cartoon, but in reality, doctors and nurses actually has a lot of things to learn, and we need to go to the science to find out how can we improve the communications with patients. And all the research that we do in the lab has to make an impact to the patient in order to fill the theory practice gap. Otherwise, the research is useless. So when I do my research, I always consider what are the impacts that I can make to the patient and to the society. Now, this slide is very crowded. Actually, it shows all the impact that a society expects the researchers to be able to produce. You know, to do research actually costs a lot of money, right? We spend money on doing research and studies. So what are the benefits we can benefit to the societies? There's a lot of expectations from the community and the societies. And I just highlight a few yellow font with you, the box with the yellow font. These are some examples of impact that the society expect the researcher to produce in ACP research. That include some like improve health or welfare outcomes, enhance professional standards, guidelines for training, to arouse public debates, how to shape the decision in advance directive, how to improve the quality and efficiency of a public service, and how to make more effective management of workplace practice. So these are just some examples of impact that we as researchers need to consider. So my favorite letter, alphabet letter, is letter C. So I really like letter C because my name is Carmen Chan. And the 4 C's of targets that I always take into serious consideration in my research is community, clinicians, clients, and culture. And the most important C is compassion. So from the last 20 years of my research journey, actually I have experienced how can I extend my research from bench to bedside and from classroom to community in order to benefit more people who need the care. My mission of research is the promotion of quality and effective cancer and palliative care through the development and utilization of evidence-based knowledge. So this is the cancer continuum from prevention, screening, diagnosis, treatment, recovery, and end-of-life care. And I do research in all phases of a patient. So I will follow the patient throughout all these stages. And these are just some example of my funded project throughout the cancer continuum. And what I'm going to share today will focus more on the end-of-life research on ACP. So before year 2010, we have some understanding about how people in Hong Kong see advance directive. We have research findings showing that actually the elderly and the patients with chronic illness, they are very acceptive. They are very eager to talk about their plan and how they want to plan for their funeral and how they want to have comfort care, etc. It's very positive. However, the family members usually are the one who say no. They are the one who rejects the idea. So in a study in year 2007, we find that 60% of the family are not willing to forego life-saving treatment for their loved one. They have a strong sense of guilt and thinking that if they forego the treatment, it means that they do not treat their family parents, they did not fulfill the filial piety. And they also have a strong death taboos and uncertainty about what is AD. So in year 2006, the Hong Kong government has done a public consultation, but in my opinion, that consultation was not very successful because only very small number of people respond to these consultations. So at the end, the Law Reform Commission of Hong Kong government concluded that people in Hong Kong are not ready for a statutory form of AD at that time, but they agree that the government should keep an open mind and do regular review of the situations, and until the public and the community are more aware and open to the idea, then they will reconsider the statutory form of AD. So that aroused me to do my first research findings. I realized that in order to promote advance directive, the first step is to work on the community. The first step is to arouse the community awareness of what is Advanced Directive and what is ACP. So my first study in year 2009 is to promote advanced care planning, which is a multidisciplinary project working together with nurses, physicians, and Michael is a team member of this study. And at that time, we published the first Chinese health menus on advanced care planning, and we printed 3,000 copies of these health menus. We conducted roadshows together, free, I think it's 8 roadshows. We did 3 in the shopping centers, 5 on the hospital lobbies, and we had the opportunity to get into contact with 2,800 general public citizens to promote the idea of Advanced Directive to them. We also did a very short survey to these participants, and we find out that actually 87% of general people in Hong Kong have not heard about Advanced Directive at all. And after this roadshow, we did a workshop for nurses and doctors, social workers, and psychologists. So actually it's a 3 days, very long, intensive workshops, and we repeated the workshop several times to promote the idea of ACP, and also we have some training about the skill and step in doing ACP and Advanced Directive. And after the training, after the workshop, we encourage the healthcare professional to go back to the front line and go to the bedside and do what you have learned in the workshop. So after 3 months, we did an evaluation on the client. Actually, we find that the clients, the patients, and the family members all has very positive feedback to the care that they receive. They find that they reported better quality of life score, better family care satisfaction score, and we find that there's increased participation in ACP, like more patients are willing to sign do not resuscitation order, more patients are willing to establish living will and Advanced Directive. And also very important is the hospital readmission rate is also decreased. And then even though they readmit, the stay is shortened. So we are very happy with the outcome of our workshops. However, when I look back, I find that the workshop actually is very time consuming. It took 3 days, and actually it's very labor intensive. It took around 10 speakers. We invited speakers from various disciplines to give the talk. Actually, it's very time consuming and very labor intensive. And during the implementation of the ACP, we got some feedback that the influence of family members are still very, very strong. So if the family member reject the idea, no matter how hard you try, the patient will not comply to having an AD. So with this experience, I decided that I must go back to the community and take the root cause. What make the people have barriers? What are the barriers and facilitators of engaging in Advanced Directive? So I adopted a shared decision-making model that involve healthcare teams, the family member, and patients. So this is my second study on ACP, is to develop a conceptual model to predict the acceptance and completion of AD in Hong Kong. So let's see. Okay, this is a conceptual mapping studies. The goals of the study is to identify the perception and influencing factors surrounding Advanced Directive. Firstly, I will interview a variety of stakeholders, including patients, healthcare professionals, family members, and some healthy volunteers. And these healthy volunteers can represent the view of the general public. And the second objective of this study is to produce a conceptual map that helps to graphically display the relationship of various factors to explain Advanced Directive acceptance in Hong Kong. All right, so concept mapping actually is a very innovative research approach. It's very suitable for palliative care research because palliative care adopts a shared care model that emphasizes the collaboration among patient families and healthcare providers. So it's an all-parties game in palliative care. And concept mapping is an approach that can best capture a whole picture, a big picture, as well as some clustering of sub-themes graphically in terms of the topics in advanced directive. All right, the picture can't be displayed. Now, the concept mapping approach is very good because it can capture the shared expertise of a study group, and it has the benefits of mixing qualitative and quantitative data to strengthen the evidence. Now, the concept mapping approach actually is a very systematic, very structural approach. It helps the researcher to stay on task. So you can't be lazy. You have to do one and then move to the second. And then also we engage the participants. So firstly, we will identify some 96 participants to conduct a qualitative interview with them. And then from the interview, we identify a long list of statements that are relevant to advanced directive. And we also do some literature review. And after that, we sort the statements into different piles. And then we also give this statement back to the participant, the interviewer participant. We give it back to them and ask them to rate what is the importance of this statement. And after they make the rating, we use some statistical method, the multidimensional scaling analysis, to produce conceptual maps. And after the map is produced, we need to give the cluster name, all right? So we produce some name and finally develop the concept map. All right, slide 49. Okay, slide 49. Yes, all right. I think slide 48 cannot be shown, right? You cannot show slide 48. 48, please. Something is missing in the slides. Oh, so sorry. Okay, actually, slide 48, I want to show you the cluster that is produced by the graphic, but something wrong with the system again. So anyway, I'll show you the cluster of the factors. In the concept map, actually, we have 6 important clusters, 4 on one side and 2 on the other side. Okay, the 4 on the one side is closer to each other. That means they are more closely related. Are the physical factor, personal factor, value system, and socio-cultural factors. In physical and illness factors that concern the patient's perception of what is health, okay? What is their current health status and how they perceive suffering and how they perceive their goal and what do they expect from their illness. The personal situation concern about the age, the sex, and the family incomes, and other factors that concern about the person as on their own. The value system is the patient's philosophical thinking of life and death. What is the most important thing to their life? Is family more important or their career more important? The socio-cultural factors concern about the family values, how they emphasize the family opinion on their own decision making in healthcare. Now, the last two factors are conditional factors and logistic factors. Actually, will display on the left side of the map because they are related. They are concerned about the logistic and process of concept of AD. Conditional factors concern about the condition when the patient is signing the AD. So they care very much about the physical and emotional condition. They want to make sure that I am competent and emotionally stable when I engage in the AD discussion. And the logistic of AD concerns about when, where, how, and what to do in AD. So they care a lot about the communication skill, the environment, whether it's the right time, right place, and the right person to do AD with me. So, and besides of the statement, we also give the statements to the participants to make a ranking. And we find out that in the rank of 1 to 7, the highest ranking is conditional factors, rank 5.6. That means the patient, the participants think that it is extremely important that a person must be competent when they make such decision. It must be, the person must be very stable physically and emotionally in order to make that decision. And the least important factors are socio-cultural factors. Even though they are different, but you can see that the difference actually is very small. It's only 0.7. That means all the factors are kind of equally important. We do not find any factors that are unimportant in terms of engaging in AD. All right, so what we learned from these studies, the results actually reflect to us the importance to consider Chinese cultural context. We need to involve the family, and it also highlights the importance of the communications process. So in terms of clinical practice, when we talk about AD with the client, we need to stress the purpose and the benefit of the AD is for the whole family as a whole. It's not only benefits the patient, but it's also benefits the whole family. And we also need to emphasize the transference of communication skill and the tact of the caring practice. In terms of the application of the map, slides 51, okay. Yes, so we make use of the concept map to develop a questionnaire for a large-scale population survey. We have interviewed 2,002 participants through a telephone survey, and we find that only 80% of them has heard about AT. Majority of them agree that AD is a human right, but the promotion of AD in the community is inadequate. So this survey finding echoes the qualitative results, so that means they validate each other and strengthen the validity of the findings. And in short, more promotion of AD is needed to arouse the public interest, more training communication skill is needed, and when we do all these things, we need to be aware of the cultural element. I have several other funded projects that I do together with Professor Helen Chan, include, for example, the ACP promotion for residential care workers. We develop some micro movies to empower the senior citizens, and we also do something on pediatric cancer patients. So all these works, actually, I have learned a lot from these experiences that help me to build the ACP training programs in the future. So in terms of the impact of these ACP studies, first of all, clinical impact, we are happy that with the promotion of ACP, actually we reduce hospital readmission, we reduce the family burden, unnecessary healthcare costs, and we also revolutionize the promotional activities. Instead of just talking roadshow, we actually adopt the use of technologies like handheld tablets, online platform, and micro movies. And in community and cultural impact, we have do a lot of life and death education for the general public, including 8 roadshows, 3,000 health menus, free radio talk shows, 2 websites, and 3 mobile apps. And with a concerted effort of many research work together, we are happy to know that the fear of death score in Hong Kong actually decreased from 4.4 to 3.4 within 7 years. And the quality of death index improved from 31 to 22 within 5 years. All right, so now I want to talk a little about nurses, because year 2020 is the International year of nurses and midwifery. So I will share a little bit more about the nursing research on nurses. So we know that nurses is the only healthcare professional that are able to access some disparate populations throughout the illness trajectory. No matter the patient receiving care at home, in the elderly center or hospice or hospital, there are nurses all over the places. And as the largest workforce in global healthcare, nurses take a strategic position to influence the quality of palliative care. And in talking about advanced care planning, nurses has a very important role in leading the ACP implementation and creating a system-wide cultural changes to improve the end-of-life care. However, we have findings to show that nurses in critical care settings has low involvement in ACP discussion. But it's not a surprise because ACP discussion in acute care is not an easy thing at all. It has a lot of challenges. Next, okay. So we know that ACP communication itself is a very sensitive and challenging conversation. We need to identify when to have the conversation. What is the best time to do it, and do we have time to do it? Sometimes nurses can be oversimplified the decision-making process that miss the main point. And as a nurse, we need to deal with different perspectives, with the perspective from the healthcare professional, family, and members. And busy is a reality, it's not a complaint, all right? So it's really busy, and with many emergency things happen in the acute care ward. So we really need to think of, go back to the science. We really need to find a way to tackle all these challenges. So we look at the theory and see how the theory can help us. So according to the theory of planned behavior, we know that there are some barriers for nurses in acute care setting to do advanced care planning. If we can tackle these barriers, probably we will have some silver lining, okay? So first of all, lack of control. If the nurse do not have enough education and training, they don't have control, they don't have the sense of competency. And there's incongruent organization and professional norm. Whether my boss supports me to do it, what I have done, would I receive recognition from my peers? These are important barriers. And conflicting personal attitude, whether the nurse think that ACP is important or not, and whether ACP is valuable or not. The slides actually move very slow. So when I click the button, it doesn't move to the next slide. So, okay, next. All right, so the way forward, what can we do? Now, we all know that nurses need some training. We need to provide training for nurses working in the non-palliative care unit. But how to make it successful? From our experience, if we want to make changes, if we want to change someone's behavior, it's not an easy task. We must go back to the theory. We need to, based on the theory, to develop an intervention. And the intervention is also guided by the evidence-based knowledge. So, and one of the editorial feedback said your manuscript is both good and original, but the part that is good is not original, and the part that is original is not good. So I really hope that the research that I'm going to do is both good and original. So I do not copy others. So it has innovations, but the innovation part is also good and realistic and beneficial to the patient. Now, this triangle actually is very famous triangle of the evidence-based practice. I think you are familiar with that, that the level of evidence actually increased from expert opinion, qualitative study to single RCT, and the top level is the systematic review of randomized control trial. So sometimes we regard evidence-based practice is like systematic review, the meta-analysis of the RCT. But my personal opinion is I would prefer an integrated review that combines the meta-analysis of RCT and also the meta-synthesis of the qualitative study so that it will capture the whole pictures of what's going on, especially for topics in humanity and social science topics. So I go back to the literature to find out the evidence. In year 2019, my team and I did a systematic review, and we identified the outcome as the professional knowledge and attitudes toward ACP. We searched the literature on how to improve the research or literature related to educational interventions in non-palliative care settings. All right. So this is the findings. So we actually identify 4,000 literatures, and after a stringent procedure of screening and sorting and screening, we ended up with 10 studies that are of good qualities for in-depth reviews. So in the result actually involved 1,081 participants, and all the included intervention studies show positive effect when the education using small group discussion and interactive mixed mode learning strategies. And the results also find that decision aid and organization norms are two major facilitators. However, the systematic review also find that the existing randomized control trial are not of high quality. So we have to do one that is in good quality, good and original. And so when we adopt this intervention to the clinical settings, the appropriate use of decision aid is good, and also organization support is a key successful factors. All right, so besides a literature review, I also do a qualitative interview with 13 nurses working in acute care setting to ask them how can we make our education intervention more user-friendly. And their findings tell us that they prefer the use of multimedia and experiential learning rather than just talking, all right? And in order to build their confidence, they suggested more role-based practice, more sharing of case study and practice, and in teaching them how to use the decision aid. And so in summary, from the systematic review and from my qualitative research, we have these findings that how to make the intervention more successful is by small group discussion, experiential communication skill. So we will adopt the use of enhanced lecture and use of standardized patient. The multimedia technologies such as mobile apps and interactive e-learning, patient e-stimulation is useful. And of course, we will include decision aid. So we have talked about the evidence-based part, and now we move on to the theory part. So what theories can guide us to produce a successful and useful education intervention? Now, we adopted the theory of planned behavior. In this theory, they emphasize 3 elements that are very important to promote behavioral change. These 3 elements are attitude, the personal attitude of the nurses, the subjective norms, the perceived behavioral controls, and all this will produce changes. Will make the nurses has more intention to change, and eventually will change their behaviors. So when apply this theory in my interventional study, we provide an ACP training program to the nurses, and the goal of this training program actually is to tackle that 3 elements. So we will highlight the high value of ACP, we will emphasize the organization norm, and we will also improve their perceived self-competency in conducting ACP. And with these support and elements, we hope that the nurse will be more willing to make change, to discuss, and eventually they have higher frequency of ACP discussion with the patient and client. So another theory I will use to, in terms of pedagogical approach, is the experiential learning models, because that is what the nurses told us, that they prefer some action rather than just talking, all right? So in this experiential learning model, it emphasizes the importance of experience and reflection in the whole learning process. Basically, it's a cycle. It's not a linear thing. It's a non-stop cycle. Even though after the training sections, in day-to-day practice, the nurse still encouraged to adopt these experiential learning models in their practice. So this model has 4 elements. Start from active experimentation, okay? Just do it like an experiment. So in this part, we will do a mobile app training. We will provide a skill building workshops, and this will take a step-by-step approach to guide nurses how to implement ACP. And after this active experimentation, we will give the nurses some concrete experiment, a concrete experience by role play their AP discussion with a standardized patient. And after this role play, we will have discussion about the good thing and the bad thing. What have you done properly and what have you done improperly? So in this discussion, actually is a good reflective observations. And then the nurses can kind of identify ways to improve herself in real life practice. So this is the experiential learning cycles. In order to provide more training sections, we have to seize every opportunities and make a very economical use of resources, because the more practice is the best. So how can we produce and create more practice for the nurses is the direction that we look for. So the objective of my MEACP project is to have several objectives. First of all, to develop a MEACP training program for nurses working in the acute care settings, and then we will evaluate the effectiveness of such interventions in terms of their knowledge and skill. We want to evaluate how nurses perceive the training session, whether they are happy with our arrangement or not. And we want to assess the actual number of ACP implementation 12 weeks after our workshops. And finally, we need to validate the theory, because the whole thing was developed based on a belief. We believe that with changes in the nurses' knowledge and confidence, then the skill will be changed. And after the skill is changed, the practice will be changed. So this is just a belief, and we need to use some data to test and validate whether this belief is true or not. And so in this figure, this is a hypothetical path model to show the validation of theory. I won't go into details, but basically we want to use the data to find out that the nurse confidence and the knowledge will actually change the nurse attitude in conducting ACP and eventually change the skill performance. So in our intervention group, the package, so the intervention group, nurses in the intervention group will receive the MEACP training package that includes a mobile apps of training program before the workshops. So we will expect the nurse to learn on their own. It's like a self-directed learning from the mobile apps before they come to the workshop, because we don't have time to do a 3 days workshops anymore in acute care settings. So we expect the nurse to learn most of the foundational things in the mobile apps, and then they come back to have a 3-hour multimedia workshops. In this workshop, we will use enhanced lecture and role play encounter with standardized patients, and we will also let them practice the use of the decision aid. So at the end of the workshop, all nurses will write a reflective journal of what they have learned and what they have experienced in the workshops. So our interventions has several features. I will explain a little bit more of these features to you. So we use mobile apps. So why we use mobile apps? So as mentioned earlier, that nurses in every setting actually is very busy. The work environment is very chaotic. So we need to maximize their time of learning. So we put most information in the mobile apps that nurses can learn at any time, anywhere at their convenience. And with this added information, we hope to increase the nurses' confidence. And in this mobile app, we also equip with instructional elements and controversial case studies. So it's not only information giving, but we also provide an opportunity for the nurses to reflect what is the good practice and what is the bad practice. So after the mobile app learning, when they come to the workshop, in fact, we will use enhanced lecture rather than a conventional lectures. Like today's presentation is a conventional lecture. It's 1.5 hours long. I think it's too long. Actually, I probably lost all your attention after 1 hour. So in my workshop, I will not use a conventional lecture like this. I will use a series of enhanced lectures, which is like 10 to 15 minutes of mini lectures. And after each mini lectures, I will add some activities in between and then start the mini lectures again. So these activities such as discussion, small group discussion, role play, short write or quizzes, something for the participants to do to engage them. So this approach is action-based, team-based, and inquiry-based of learning. And we have statistics to show that this type of learning actually can promote deep learning rather than just head knowledge. And we also mentioned that we will use standardized patients for role play instead of asking the participants to role play among themselves. Why I have to use a standardized patient? So now standardized patient is not a patient. Actually, they are actors. Okay, they are actor being trained to portray the patient's characteristic and reaction in a scenario. And standardized patient is commonly used in medical and nursing education to assess the students' clinical skills. So we have research finding that standardized patient actually has been used before to compare the decision-making skill between trained and non-trained nurses. It facilitates a more consistent experience simulated to the real clinical setting. It's also a more accurate measurement of the nurse's ability, much better than self-report or paper questionnaire. So this table just summarized to you how I incorporate the two theories in these interventions. So on the left column is the theory of learned behavior. So and the second column is the format and content of the ACP. So you see that in the first row, the mobile app training, actually we hope to have an impact on the behavioral attitude. And in the mobile app, we will provide information to the nurses. We put 10 modules with real cases study, a lot of videos, quizzes, games, and feedback all included in the mobile apps. That should to the experiential learning cycle that we provide some experiment to the nurses. We also provide opportunity for reflection and abstract thinking in the mobile apps. Now, in the skill building training workshop, we hope to make change, tackle the perceived organization, professional norms, and also personal behavioral control. So in this skill building workshop, we will use enhanced lectures, we will use multimedia presentation, we will let the nurse to practice the use of decision A, and then ask them to role play with a standardized patient. And after the role play, we will give them immediate feedback and discussion. All this provide great opportunity for the nurses to have an opportunity to reflect their practice. So Nancy, this is Nancy. She is the speaker of our workshop, and she is an advanced practice nurse, and she helped us to give the talk in the workshop and also be a convener for the discussion group. Actually, we are very grateful because of the COVID-19 and the hospital still allow us to do a small pilot study, and they treat this as a continuous education for the nurses in the acute care setting. So we are very grateful for these opportunities for us to test out the feasibility of the intervention. And as mentioned, Nancy is the intervener. She's an advanced practice nurse with 15 years of clinical experience in palliative care. So both the intervention group and control group has the same intervener to ensure the consistency, and the training of the standardized patient is also provided by the intervener. And after all things, we hope to have some positive outcomes in terms of increasing nurses' skill performance on decision support. We hope to enhance the nurses' attitude, knowledge, and level of confidence in conducting ACP. We will evaluate whether the nurse is happy with our arrangement or not. And lastly, and most importantly, is the actual implementation of ACP. Are there any changes in terms of the clinical in the front line, whether the ACP discussion has increased or not? In our study, we also have a placebo control group. It's a 3 hours workshop, but the delivery strategy is a didactic lectures with theoretical input only, so they don't have the mobile apps. And we also encourage the control group to have discussion and role play, but they will do this among themselves without a standardized patient. So they don't have multimedia material, they don't have reflective journal, they don't have standardized patients. So basically we are comparing the two types of educational interventions and see which part is more effective and successful. So for all the research that we do, we must have a good impact on the patients. Otherwise, it becomes a waste of resources. And I really hope that the study that I'm just share with you have the following significance and impact. I hope it has the potential to improve the nurses' decision support skill and active participation in ACP discussions. I hope to offer new insight and feedback to change both the attitude and the behavior of the nurses. And in this pilot, I want to explore the workability of such a training program in a busy clinical settings. So at the end, I really hope to promote the integration of ACP discussion in a very busy day-to-day nursing practice and enhance quality end-of-life care in acute care settings. So from our small pilot study, we learned a little things about ACP and AP discussion. First of all, don't talk too much. Actually, we don't need to worry that what to say, because if you spend time with the patient, they have a lot to tell. They are eager to tell you what are their goals and priorities. All we need to do is to give them an opportunity to express their fear and concerns and worries. Sometimes we will need multiple encounters. We need to assess the patient's readiness. If they're not ready, they may just talk something superficial with you. That's okay. You just build up the rapport and try again next time. And usually after multiple encounters, the patient is able to tell you what is deep in their heart and what they really want to make the decisions about their end-of-life plan. At last, I want to share something with you is about early palliative care, because what I have done earlier is all about early training to nurses and doctors and healthcare professionals, with the hope that we can have early implementation of palliative care for patients in an acute care settings. So Cochrane Library actually has done a very good review on this early palliative care for cancer patients. So this is a list of the results, and one of the famous studies is by Tamil in year 2010. He compared care with conventional palliative care, all right? And after the comparison, they find that the patient in the early palliative care group actually has improved quality of life and less aggressive care at the end of life. But most importantly, it also increased the overall survival of the patient who received early palliative care. And another study by May in 2015, actually he find that for patients who who received early palliative care actually has 25% reduction of cost of care. So it has financial benefits and impact to the client. And so what does early intervention means? So it's a clinical decision. How early is early? All right. So it's a clinical decision based on the metastasis condition of the patients, the advanced disease, whether the patient is receiving curative or palliative care treatment. And we need to consider how heavy is the disease burden to the patient. What is the functional status of the patients, their social circumstances, and their wish and want. And my ultimate hope is that the clinicians, patients, and family should have rapid access to 24/7 palliative care advice, no matter where they are, okay, and where is the setting that they are practiced. So patient-centered communication and shared decision-making is also considered an important part of early palliative care. So how early is early, okay? So in the study in year 2015, earlier study find that actually if you can deliver palliative care within 2 days after the diagnosis of cancer or other life-limiting illness, the effectiveness will greatly enhance. So, but there's also other benchmarking criteria published by the Australian Commission on Safety and Quality in Healthcare. They recommend that whenever a patient and family member express interest, we should start talking. And when a life-limiting condition is diagnosed, when a patient who is likely to die in a short term, when a previously well patient has suffered an acute life-threatening event, such as trauma or burn and fire, and any unexpected significant deterioration, and when a patient is dying, of course, is the appropriate time to start this decision-making conversation. So my reflection on early palliative care is we need to think about when we mention about early palliative care, do we mean early referral a patient to palliative care team, or we mean early transfer a patient from the acute ward to the palliative care ward, or whether we are able to have early implementation of palliative care in a variety of settings that include the patient home, the elderly center, the outpatient unit, the hospital or hospice. So if we want to do early palliative care, we have to do early ACP alongside, because we need to make the patient aware that they are receiving palliative care. We need to make them agree to receive supportive palliative treatment alongside with their curative treatment. So for early ACP actually required continuous improvement in public awareness and acceptance. We need to improve the clinician's competency in terms of their attitude, the organization norm, the personal control through reflective and ongoing learning. And lastly, I think the use of technology would be very important because we have statistics to find that actually in terms of pain control and symptom management, hospital setting can do much better than community settings. However, in terms of psychosocial care and family time, in fact, the community setting can do better. But my goal is how to mix the two together, how to merge them together so that patients and family can benefit from early palliative care, no matter what kind of settings that they are receiving the care. So e-health would be one of the technologies. E-health would be one of the strategies that facilitates this mingle. All right, and I have several future projects in my mind that I really want to try out the promotion of ACP in different settings and populations. So I just mentioned to you about this pilot study, and I really hope that I will have the chance to do a full study, because if this study is successful, it could be a prototype, like an exemplar for us to consider to train other palliative service, not just ACP, for example, symptom management and psychosocial care, or even spiritual care, we can adopt the same type of strategies to train nurses and doctors in acute care setting to provide palliative care service. And the next study I'm interested in is a supportive hospice and age residential care exchange program. I want to have some staff exchange so that they can learn from each other. And I will also plan to do some promotion of end-of-life education to university students, ethnic minorities in Hong Kong, and also Chinese immigrants in New Zealand and Australia. So these are all ideas on my plate. And I really hope that with this, I really hope that I still have a few years time for my research career, that I can complete all this dream work. So I thank you so much for your attention, and sorry again for all the interruption. And I really want to share with you my appreciation of my team of researchers in my cancer and palliative care research group. So without their passion and concerted effort, all this research dream cannot come true. So it is actually a team-based work. So I hope you enjoyed the presentation today. Thank you very much.